Very good morning. Today we will be seeing a class on periodontal treatment of medically compromised patients and older adults. So the learning outcomes includes at least listing of 5 major systemic diseases that has an impact on periodontium, explaining the management of patients with cardiovascular problems, relating pregnancy to periodontal disease, describing the role of systemic diseases on periodontal destruction and its effective management, name 5 changes in periodontium in older adults and describe their management. So these are the contents of the lecture. Patients seeking dental care have medical conditions that may alter the course of their oral disease or the therapy provided. The older age of an average periodontal patient increases the likelihood of underlying disease. Therapeutic responsibility of the clinician is needed for proper identification for patients' medical problems to formulate proper treatment plans. So these are the list of cardiovascular diseases where we have to make certain changes when we are to do any dental treatment. Hypertension, ischemic heart disease, congestive heart failure, cardiac pacemakers, and those patients with implantable cardiovertebral defibrillators, infective endocarditis patients, cerebrovascular accident patients or stroke, previous cardiac bypass surgery patients. So, coming on to hypertension first, so according to the JNC 7 guidelines, so this is the classification of adult blood pressure and what are the dental treatment modifications you have to do when the patient is having an higher blood pressure. So, normally we know that the blood pressure, normal blood pressure is less than 120 and less than 80 diastolic, so there is no changes in the dental treatment. Same way, if the patient is in a pre-hypertension stage, also there is no could be any treatment, but just monitor the readings at each appointment. When it is stage 1, that is above 140 to 159 or 90 to 99, inform the patient's finding and routine medical consultation or referral is important. Monitor the changes of BP and there is no changes in the dental treatment required, but minimize the stress. When it is stage 2 hypertension, that is when it is more than 160 and diastolic is more than 100, inform the patient, get a medical consultation or a referral, monitor the BP at each appointment. But if the systolic BP is more than 180 and less than 180 and less than 110, you can perform certain selective dental care while minimizing the stress. But if it is above that, immediate medical consultation is required and you can perform only any medical emergencies, that is to alleviate the pain, bleeding, infection or minimizing the stress. And it is always better to have afternoon appointments because there are lower blood pressure levels, and to have to avoid LA containing epinephrine because it's a vasoconstrictor. Next, coming on to the ischemic heart disease. So one of the main problems of people with ischemic heart disease is angina pectoris. So here the condition is that the myocardial oxygen demand exceeds the supply and therefore this results in a temporary myocardial ischemia. So these people can undergo elective dental procedures, but such people should always have nitroglycerin by the side. So they should be instructed to bring the nitroglycerin to all the dental appointments. Restrictions on the use of local anesthetics containing epinephrine. Myocardial infarction is another stage of angina pectoris wherein dental treatment is generally deferred for at least 6 months after MI because of peak mortality occurring during these particular 6 months. So be very specific that you don't do any dental treatment excepting the emergency treatments for the 6 months after the myocardial infarction has the patient has been having this condition. If there is an angina attack during a dental procedure, what should you do? Discontinue the procedure and administer 1 tablet of nitroglycerin sublingually. So this has to be placed sublingually because there is an easy dissociation of the tablet. Reassure the patient and loosen his restrictive garments. Administer oxygen to the patient, and if the symptom ceases within 3 minutes, it's fine. Complete the procedure, making sure that the patient is convenient. But if it is not ceasing within 2 to 3 minutes, administer another dose of nitroglycerin while calling the patient's physician. A third dose of nitroglycerin to be given after the second one after 3 minutes. See, if the chest pain is not relieved after that also, please transport the patient to the immediate emergency facility possible. Congestive heart failure. So this is another condition in which the pump function of the heart is unable to supply the sufficient amounts of oxygenated blood to meet the body's needs. So patients with poorly controlled or untreated CHF are not ideal candidates for elective dental procedures. So these patients have the condition of orthopnea. So dental chair is adjusted to a comfortable position for the patient. Orthopnea is a condition in which there is an inability to breathe unless the patient is in an upright position. We usually do dental procedures when the patient is in the supine position. So in such patients, try to raise the chair and then do your procedures. So basically, in these patients, short appointments are required. Stress reduction with local anesthesia, possibly conscious sedation is required, and there should be use of supplemental oxygen. Cardiac pacemakers and implantable cardioverter defibrillators. So patients who are having problems with their pacemakers, that is the SA node, they are fitted with the cardiac pacemakers. So especially those with cardiac arrhythmias. So initially there was an old pacemaker which was fitted to the patients, which was unipolar, and this was disrupted by the ultrasonic and the electrocautery units. But later you have the newer pacemakers. Nowadays newer pacemakers are made where it is bipolar and it is not affected by the dental equipments, especially your magnetostrictive handpieces. Since it is having a magnetic field, it has been found to disrupt the older pacemakers which are unipolar and which is unshielded. But nowadays the newer pacemakers, that is a bipolar pacemakers, they are shielded and it's not affected by the dental equipments. Automatic cardioverter defibrillators activate and endanger the dental treatments, and therefore sudden patient movement could be there, and therefore there could be any trauma which is injured given by the dentist to the patient. So be careful. Stabilization of the operating field during the periodontal treatment with bite blocks or other devices can prevent unexpected trauma. Coming on to the next disease, that is a condition, that is infective endocarditis. So you would have read a lot about the antibiotic prophylaxis as well for this. Diseases in which microorganisms colonize a damaged endocardium or heart valves, and that results in endocarditis. That is, most of our endocardium is getting inflamed. So infective endocarditis prophylaxis should only be recommended for cardiac conditions with highest risk of adverse outcome from any of the dental procedures. Antibiotic prophylaxis is recommended for all dental procedures that involve manipulation of the gingival tissues, periapical tissues, and perforation of the oral mucosa in infective endocarditis patient. So the standard regimen is amoxicillin 2 grams 30 to 60 minutes before the procedure. If he is allergic, then clindamycin, azithromycin, or cephalexin can be used. If he is unable to take oral medications, he can be given ampicillin as an IM or an IV. Unable to take oral medications, allergic to penicillin, you can give clindamycin or cefazolin. Now coming on to guidelines for patients susceptible to infective endocarditis, all periodontal procedures including probing require antibiotic prophylaxis. Oral irrigators are generally not recommended because they induce the bacteremia. Patients with aggressive periodontitis should be given tetracycline 250 milligrams 4 times daily for 14 days to reduce or eliminate AA comitants presence. Pre-treatment chlorhexidine rinses are required to reduce the number of the patient visits each time to the clinic. Allow at least 7 days between appointments. Regular recall appointments with an emphasis on oral hygiene reinforcement and maintenance of periodontal health are extremely important for patients susceptible to infective endocarditis. Next condition is cerebrovascular accident. So a physician's referral should precede periodontal therapy if signs and symptoms of early cerebrovascular insufficiency are evident. Long-term chlorhexidine rinses may aid in plaque control in such patients. No periodontal therapy should be performed within 6 months of the occurrence of any cerebrovascular accident, because the risk of reoccurrence is more common during the first 6 months after its incidence. After 6 months, periodontal therapy can be performed, but at short intervals, and concentrations of epinephrine not greater than 1:1 lakh are to be contraindicated. Supplemental oxygen is indicated to maintain through cerebral oxygenation. Stroke patients are frequently placed on oral anticoagulants, so this has to be monitored, and BP is to be monitored in such patients. Next, coming on to endocrine disorders, which includes diabetes, thyroid and parathyroid disorders, and adrenal insufficiency. So coming on to diabetes, so a diabetic patient, we have most of the patients who come to our clinic, 50 to percentage of the people are having the condition of diabetes. So they require special precautions before periodontal therapy. Periodontal therapy has limited success in the presence of undiagnosed or poorly controlled diabetes. HbA1c of less than 10% should be established before the surgical therapy, and tetracycline antibiotics are to be given in combination with scaling and root planing. So it has been found by studies that positively influences a glycemic control. So I think you guys already know what is the normal glycemic level control, that is 4 to 6, and above 7 it is considered to be that the patient is diabetic. Above 8, then it is suggested that the patient takes action to control diabetes. Hypoglycemia is a normal condition or a normal complication which occurs in diabetic patients taking insulin because of symptomatic low blood glucose level. So that results in hypoglycemia, and the signs and symptoms include shakiness, tremors, confusion, agitation, sweating, tachycardia, dizziness, feeling of impending doom, unconsciousness, and seizures. So generally, hypoglycemia does not usually occur until the blood glucose level falls below 60 milligram per dl. So when planning for dental treatments, it's best to schedule the appointments before or after the peaks of insulin activity. So patients taking insulin, they're at higher risk, followed by those with sulfonylurea agents. Metformin and thiazolidine generally do not cause hypoglycemia. Coming on to the treatment of hypoglycemia, checking the pre-treatment glucose with the patient's glucometer, checking again during long procedures, and checking again at the end of the procedure provides a better understanding of the patient's insulin pharmacodynamics and helps prevent hypoglycemia. So when the patient is having hypoglycemia, it is better to provide him with 15 grams of oral carbohydrate, or give him 20 to 35 percentage of dextrose IV, give him 1 milligram of glucagon IV, 1 milligram of glucagon IM, or subcutaneously. Reduced before the insulin dose has to be reduced before the procedure. Coming on to the thyroid and the parathyroid disorders, periodontal therapy requires minimal alterations in patients with adequately managed thyroid diseases. Patients with thyrotoxicosis and those with inadequate medical management should not receive periodontal therapy until their conditions are stabilized. Coming on to adrenal insufficiency, so some of the manifestations of it is mental confusion, nausea, vomiting, hypertension, syncope, loss of consciousness, and coma. Acute adrenal insufficiency is associated with significant morbidity and mortality as a result of peripheral vascular collapse and cardiac arrest. History of recent or current steroid used is to be taken. Physician consultation is indicated for such patients. Individuals who are at high risk for adrenal crisis require supplementation, includes those who are going for lengthy procedures, surgical procedures, those expected to have significant blood loss, and those having extremely low adrenal function, that is ACTH stimulation test. It is tested to that if they are having a low adrenal function. Glucocorticoid coverage regimens vary, but most provide a twofold to fourfold increase in coverage. Management of patients in acute adrenal insufficiency crisis is as follows. Terminate the periodontal treatment, summon medical assistance, give oxygen, monitor the vital signs, place the patient in a supine position, and administer 100 milligrams of hydrocortisone sodium succinate IV over 30 seconds intramuscularly. So coming on to hemorrhagic disorders. So there are a list of again 6 hemorrhagic disorders. We will see about them. First is the coagulation disorders. Probing, scaling, prophylaxis can be usually done without any medical modifications. Antihemostatic agents such as oxidized cellulose or purified bovine collagen may be placed in such sites where there is going to be increased amount of bleeding because of coagulation disorders. Antifibrinolytic agent aminocaproic acid given orally or via the IV is a potent inhibitor of initial clot dissolution. Tranexamic acid has been shown to prevent excessive oral hemorrhage and after periodontal therapy and tooth extraction. Anticoagulant medications if the patient is taking. So in such individuals, we have to be careful. We have to ask what anticoagulants they are taking. So the most common cause of abnormal coagulation could be the drug therapy. So these drugs are the vitamin K antagonists that decrease the production of vitamin K dependent coagulation factors, that is 2, 7, 9 and 10. So in such individuals, INR is usually calculated, wherein it is the prothrombin time of the patient by the prothrombin normal time to the power of the ISI. The normal procedures can be normally it is 1, INR is 1. With the warfarin therapeutic dose, it's 2 to 3. Infiltration anesthesia or scaling and root planing can be done if it is less than 3. Block anesthesia, periodontal surgery and simple extractions can be done if it is 2 to 2.5. Complex surgeries can be done if it is 1.5 to 2, but not beyond all these conditions. Often the anticoagulant is discontinued for 2 to 3 days before periodontal treatment, and INR is checked at the day of the therapy. Antiplatelet medications, especially aspirin, it interferes with the normal platelet aggregation and can result in prolonged bleeding, and it lasts for 4 to 7 days, its effect. Usually if it is in small doses of 325 milligram or less per day, then it need not be altered, but in patients taking more than 325 milligram per day, aspirin has to be discontinued 7 to 10 days before the surgical therapy. So coming on to renal diseases, renal failure may result in severe electrolyte imbalances, cardiac arrhythmias, pulmonary congestion, CHF and prolonged bleeding. The following treatment modifications should be used. Monitor the BP, check the laboratory values, that is prothrombin time, platelet time, bleeding time, platelet count, hematocrit, blood urea, nitrogen and serum creatinine. Eliminate areas of oral infection to prevent systemic infection, and drugs that are nephrotoxic or metabolized by the kidney should not be given. Local anesthetics such as lidocaine are generally safe. Following the following are the recommendations which are made for those receiving hemodialysis. Screen for hepatitis B and C antigen and antibody in such patients. Provide antibiotic prophylaxis to prevent endartitis of the arteriovenous fistula or the shunt. Periodontal treatment should be provided on the day after the dialysis, and protect the hemodialysis shunt or fistula. BP reading should be taken from the other arm. The next condition is liver diseases. So the liver is the site of production of most of the clotting factors. Excessive bleeding during or after periodontal treatment may occur in patients with severe liver diseases. Treatment recommendation for patients with liver disease include consulting with the physician regarding the current stage, the risk of bleeding, potential drugs during the treatment and required alterations, screening for hepatitis B and C, checking the laboratory value of PT and PTT, and checking the laboratory values of INR. Pulmonary diseases. So now we have the COVID condition as well, and therefore we have to be a little careful regarding this. So in patients with known pulmonary diseases, consult with their physician regarding medications. Avoid elicitation of the respiratory distress or depression. Minimize the stress. Patients with emphysema to be treated in the afternoon, several hours after sleep, to allow for clearance, airway clearance. Avoid medications that cause respiratory depression. Avoid bilateral mandibular block anesthesia, which could cause increased airway obstruction, and position the patient to allow maximal ventilatory efficiency. In patients with history of asthma, especially if asthma are frequent, ask the patient to have the inhaler in his nearby area, so that whenever he has an attack, he takes the inhaler and he does it by himself. Inhaler should be readily accessible on the countertop in the dental treatment room. Patients with active fungal or bacterial respiratory diseases should not be treated unless the periodontal procedure is an emergency. Medications and cancer therapies. So medications such as bisphonates, anticoagulants or antiplatelet therapies are given. Corticosteroids, immunosuppression or chemotherapy or radiation are types of medications which are given for the patients with cancer. So chemotherapy, if the periodontal therapy is needed during the chemotherapy, it is best done a day before chemotherapy is given, when the white blood cells counts are relatively high. Dental treatment should be done when the white blood cells are above 2000 milligram per cubic blood liter, with an absolute granulocyte count of 1000 to 1500. Infectious diseases such as tuberculosis, hepatitis, and HIV/AIDS also requires proper attention. Hepatitis, we have already seen a lot about this. The following guidelines are offered for treating patients with hepatitis. If the disease, regardless of the type, is active, please don't provide any periodontal therapy. Consult the physician. And for recovered patients, you can perform especially HAV and HEV, that is hepatitis virus A and E infections. You can perform routine periodontal therapy. And the anti-HBs antibody to the HBV anti-surface antigen laboratory test, and if they are negative but HBV is suspected, order another one. Patients who are HBs AG positive are probably infective. They are the chronic carriers, so this is measured by the HBs AG levels. Patients who are anti-HBs positive may be treated routinely. Patients who are anti-HBs negative can also be treated routinely. For HCV patients, consult with the physician to determine the patient's risk for transmissibility and current status of chronic liver disease. Acute hepatitis, positive HBs AG people, that is the HBV carrier or the positive HCV carrier. So, if a patient with such status requires emergency treatment, use the following precautions. Consult the patient's physician regarding the status. If the bleeding is likely during or after the treatment, measure the prothrombin time and the bleeding time. Hepatitis may alter the coagulation and therefore change the treatment accordingly. All personnel in clinical contact with the patient should use a full barrier treatment, including masks, surgical gloves, glasses or eye shields, and the disposable gowns. Use as many as disposable cars as possible, covering the lights, drawers, headrests, everything. Minimize the aerosol control by not using an ultrasonic instrumentation, air syringe or high-speed handpieces. Remember, saliva also contains a distillate of such viruses. Pre-rinsing with chlorhexidine gluconate for 30 seconds is highly recommended. When the procedure is completed, all the equipment should be scrubbed and sterilized. If an item cannot be sterilized, then dispose it off or it should not be used. Periodontal treatment planning in older adults. A geriatric patient is an older adult who is frail, dependent, or both and requires health and social support services to attain an optimal level of physical, physiologic, psychological, and social functioning. Dentistry for geriatric patients or geriatric dentistry emphasizes on an interdisciplinary approach to diagnosis, treatment, and prevention of dental and oral diseases. Adults 65 age and older are generally considered to be the geriatric patients. So factors to be considered in them is medical and mental health, their medications, their functional status, their lifestyle. So all is to be considered. Periodontal severity is more in such patients, but if they are able to perform proper oral hygiene measure and able to tolerate the treatment, that is well and good. For older adults, a non-surgical approach is always the first treatment. So to summarize, future oral healthcare trends will see increased number of systemically compromised and older adults seeking periodontal treatments. Dental practitioners of the 21st century should be comfortable providing comprehensive periodontal care for both the medical as well as the geriatric section of patients. A common goal for the medical as well as the older adults is to decrease the bacteria through the oral hygiene and mechanical debridement, evaluate the medically compromised patient and treat the patient based on their medical conditions also.